Hi everybody, welcome. My name is Abby Lee, Director of Marketing and Business Development here at Bay Area Regional Medical Center, and we're going to get Dr. Briggs to smile at some point, I promise. So today we're going to be talking about all things feet, and we're going to cover a lot of ground with today's conversation with Dr. Briggs. We're going to be talking about total ankle replacements to pediatrics, to diabetes, to bunions, and everything else. So if you guys have questions along the way, feel free to put your comments below. Okay, you ready?
Sure.
Okay, let's talk about total ankle replacements, because to me, I think that it's going to be like a total knee or a total hip, right?
Very much so. We're now able to replace folks' ankles with an implant, whereas in the old days we'd have to fuse these ankles. So we're giving folks a little bit more mobility that they can walk on their foot and ankle with. We've had some nice success over the years with this type of procedure, and certainly we're getting better and better at it.
Okay, so what kind of signs and symptoms would someone have that would say you're a candidate for this total ankle replacement?
Yeah, folks will often come in with certainly pain in and around their ankle. Oftentimes they'll have some swelling. Sometimes they'll complain of arthritic type of pain, particularly at the end of the day. However, this can occur with any sort of physical activity that may exacerbate their symptoms.
So they're hurting by the end of the day, and then they say, "Doc, I can't do this anymore."
That's right.
Do you go through certain phases to get to a total ankle replacement?
There are a host of conservative things that we'll try that we can often buy some people some time and prevent them from a total ankle fusion or that of an ankle arthroplasty or an implant. And we'll try injections, anti-inflammatory medications. Certainly physical therapy can be a benefit. Sometimes a period of immobilization just to calm down that area can be beneficial.
But if they have arthritis everywhere and it's not going to get better, do you say, all right, we're at a point where it's time?
That's right, Abby. I think that's a discussion that you need to have with your physician and figure out what the appropriate time is in your life when it's affecting you day in and day out, and the things that you would like to do to keep you happy and to keep you going. But our job here is to keep you walking, keep you moving, and to keep you doing the things that you would like to do. And that's first and foremost the most important.
So I've heard that total knees last a certain amount of time. Are total ankles the same way?
They are. We've got about a 90% survival rate at 10 years now, which is pretty extraordinary. So we're putting it into younger and younger folks. However, there's a certain age category that we look for these patients to be in, and we're also looking for certain activity levels.
So have you done this on like a younger person where they're going to have to get, like, do they have to get a new one after 10 years, or how does that work?
Yeah, fortunately I haven't been doing it for 10 years yet. But,
okay.
Yes, the idea is that you will have to replace a portion of the implant down the road. But what they call the poly or the polypropylene that are in these implants that act as the ankle will have to be replaced at some point. So.
Okay, so talk to me about the surgery. How long is it? How long does it take to recover?
Surgery takes a couple hours, maybe an hour and 45 minutes
That's
at
not
most. They are usually outpatient nowadays. The insurance companies are requiring this. Rehab is non-weight bearing usually for about 2 weeks. And then I have them in a protected weight bearing cam walker starting at maybe 25 to 50% weight bearing, all the way up to full weight bearing, hopefully by the week 4, week 5.
Awesome. That's almost sounds like bunion surgery.
Almost.
We'll talk about bunions in just a minute. So you got total ankle replacements, and then you have reconstructive surgery. Talk to me about the difference and what you do to reconstruct a foot.
Sure. There are many types of flat feet out there. There's all sorts of high arch feet out there. There are feet that just don't work for folks. So we're trying to align bones within the foot itself and joints so that people can walk on a stable platform. And oftentimes that requires fusing bones together or aligning bones more appropriately so they can walk with a stable gait. But oftentimes this does require a certain amount of hardware and a certain amount of rehab.
So is it mainly for people with flat feet?
We do. I would tell you the majority of the patients that we do major reconstructions on, they do have a flat foot, and that is either hereditary or caused by some tendon injuries or from trauma previously.
So I guess people know if they have a flat foot or not, but what kind of signs and symptoms would they have that would say, okay, we really need to look at a total reconstruction construction of your foot?
Sure. Pain and disability probably is the most important thing, and when to entertain that idea. If you have a flat foot and it's asymptomatic, you have no pain whatsoever, and you can do every activity that you want to do, and it doesn't slow you down, there's no reason to even consider any form of treatment. The science just doesn't prove that to be beneficial.
So are they like, if they have a lot of signs and symptoms of it, are they like unable to walk by the end of the day or stand for a certain amount of time?
Yeah, again, I think most will complain if their feet are tired or their legs are tired. They have some generalized achy pain. Sometimes they'll point to one or two areas within the foot that are symptomatic. But most of the time, the folks just get tired. They're tired at the end of the day, and they say, I can't go any farther.
Okay, so let's talk about diabetes and how that can affect your feet. I had no idea that diabetes can affect your feet.
Diabetes is a tough disease. I mean, we're seeing more and more of it, unfortunately, and with the diets in America, and certainly we're seeing it in non-westernized countries now as these countries become more westernized. Mm-hmm. These folks, as diabetes goes on, as their blood sugars become more and more elevated, and if they're not in good control, it certainly can impede their vascularity or their blood flow down to their feet. And even more importantly, or as important, it can affect their nerves down to their lower extremity. So you can imagine a diabetic who has elevated blood sugars and they cannot feel, and their blood flow is not appropriate. What a difficult time that they have to heal. And you see many diabetics out there that have had partial foot amputations or toe amputations or below the knee amputation. And this is all secondary to diabetes.
Oh,
and what it does.
wow. So you go from like having diabetes to being amputated. Like, where's the in-between?
Right. Fortunately, most of our patients will fit in the in-between category. And that's why we see our diabetic patients on a routine basis to help prevent any kind of complications to their lower extremity and try to keep their legs on. Just because you've had one amputation doesn't mean you're going to have another amputation. Just because you have diabetes doesn't mean that you're going to have any complications to the lower extremity. The most important thing I can tell everybody out there watching is just make sure you work with your endocrinologist, your primary care physician very closely, and making sure that your blood sugars are under good control.
So you have diabetics just come and see you just to get a checkup? Is that normal?
We do. I categorize all my diabetics from low to high risk, and my low risk patients I see once a year, and maybe my high risk patients I'll see every 3 to 4 months to help prevent them from having any complications.
So you were talking earlier that someone with diabetes might step on something and then not feel it and not know it. Is there some sort of tips that you give to people to make sure that they keep an eye?
Absolutely. We ask our diabetic patients to check your feet twice a day. We often put them and prescribe them diabetic shoes to help prevent certain sequelae or certain issues that can happen to them. But I think checking your feet every day and proper blood sugar control is the most important. Diabetics can live just like anybody else nowadays, provided that you're getting proper care, your blood sugars are under good control, and you're compliant with your diet.
Okay. All right. So that's interesting. I did not even have a clue on that. Okay. And you also do pediatrics. Talk to me about what you do with pediatric patients and kids.
Yeah, there are some children out there that were unfortunately born with certain deformities that we can correct at certain ages, again, pending their symptoms. And there are certain things that we'll often do conservatively to try to prevent them from having issues down the road, such as placing these folks in orthotics and bracing and what have you. But when that fails, we do have technology now that we can address some of these issues and allow these kids to have a stable platform to walk on, i.e. their foot. So.
I have a story for you, and you probably don't know this, but when I was a kid and first learning how to walk, my feet went in, and my mom said that I was tripping all over myself, and I had to wear braces.
Yeah.
And she says that that's why I love to wear high heels now.
Well, I've always known that about you, Abby.
Yeah.
And what did I tell you when I operated on you? I said, my goal is to get you back to wearing high heels.
I still am. So we'll talk about bunions too and talk about that too. That's pretty cool. So anyway, that's an interesting concept too. So yeah, there you go. Braces do help because I can walk and run and do just fine now. That's very cool.
Excellent.
Oh, bunions is next. So let's just talk about bunions.
Absolutely.
Yay! My favorite
topic. You can talk on it now. You don't need me. Let me ask you the questions.
I do know a lot about bunions now. So let's talk about how are they formed. So I have to say this, most people think that high heels cause bunions, so let's just get the record straight now.
That is not correct. Most are caused by hereditary conditions, but 2/3 are caused or do occur in women, and 1/3 do occur in men. But high heel shoes have nothing to do with the cause of bunions. There are many people out there that wear high heel shoes that never develop bunion deformities.
There you go. So how does someone know if they have bunions?
They'll notice a bump on the inside part of their foot by their big toe, and they'll have to complain of some pain. But I'll tell you, overwhelmingly, the majority of bunions do not cause symptoms. It is not warranted to fix what we call asymptomatic or bunions that are not painful. Those can be treated with just wider shoe gear, etc. But conservatively, there's not much that we can do to prevent bunions. The literature does not support any kind of taping, strapping of that magnitude that will help.
So if someone comes in, what kind of signs and symptoms are they saying when you're like, oh yeah, that's a bunion and that's what your problem is?
Yeah, they'll complain of just generalized pain within the foot. They'll complain of tiredness sometimes at the end of the day. They'll say a certain type of shoe gear may hurt them, and it certainly is progressively getting worse over the last several months. They often notice a redness area over the big toe joint.
Yeah, and mine were waking me up at night. Like, that was crazy.
Well, there you go. And sometimes the sheet's just touching them. That's a good time to probably get these looked at.
Oh, yeah. Mine were, but they were waking me up at night. And I was like, my feet are waking me up. This is crazy. So let's talk about treatment options for people with bunions.
Sure. Obviously, we start conservatively. Again, we try wider shoe gear and anti-inflammatory. Maybe it would be of some benefit. However, again, once the bunion has become symptomatic, a majority of conservative treatment options do not work, and you oftentimes have to rely on a surgical correction to realign that joint, remove the bunion, and to get you back into your normal shoe gear.
Yeah, so I am a proud patient of the bunion surgery, and I'm back in heels, so it can be done.
And we did both, I think.
Yes, both feet. Yes. So, and yay, and no more bump. It looks awesome.
Thank you.
All right, let's talk about plantar fasciitis. What is that?
So it's inflammation of a ligament that attaches to the bottom part of the heel bone. We see it in athletes, but we'll see it in an 18-year-old and we'll see it in an 80-year-old. It's really the inflammation of the plantar fascia as it attaches to the bottom part of the heel. About 25% of the population will get plantar fasciitis sometime in their lifetime, and it can be a very debilitating issue. But it's treated very conservatively in about 90% of folks, usually with the use of inserts, anti-inflammatory, stretching exercises, sometimes custom orthotics. Only 10% will need any kind of surgical correction for that. The important thing is when people talk about bone spurs, it's not necessarily the bone that's hurting the patient, it's often the ligament that's attaching to the bone that's causing the issues.
Awesome. So there's a comment right here. Before I ask any more questions about plantar fasciitis, I have Addison's disease and your staff is knowledgeable about it and always treats me well and with respect, from Robin. Aw, thank you, Robin.
Very nice. Thank you.
That's awesome. Okay, so what causes plantar fasciitis?
We don't exactly know, but we believe it's an overpulling of the plantar fascia on the bottom part of the foot. It could be due to a high arched foot. It could be due to a low arched foot. It could be due to a condition called what we call equinus, and it just means a tight heel cord. And we believe that there's small micro tears within that plantar fascia that develop and create a chronic inflammatory condition that can occur.
So when these people come into your office, what's their complaint?
Chief complaint is pain upon awakening in the AM or after prolonged periods of sitting.
Pain in the morning and after sitting. Okay. And so you said stretching is mainly what you tell people to do for this?
Stretching, anti-inflammatory medications, sometimes injections in the area. Physical therapy can be of some benefit. Orthotics.
Do you do surgery for that too?
About 10% of the time we do surgery for that.
How do you do
So we'll actually remove the bone spur that's down there and then we'll lengthen that, what we call the plantar fascia that attaches to that heel bone.
Oh, that's cool.
Yeah.
Okay. Those of you who are watching, we are here live with Dr. Briggs talking about all things feet. So if you guys have comments or questions, you guys post those below. We'd love to hear from you. Okay, so let's talk about my other favorite topic on feet. Because I have lots of foot problems.
Neuromas.
Neuromas. Let's talk about that. What causes neuromas?
Neuromas are a pinched nerve on the bottom part of the foot. It's what we call an interdigital nerve. And it's a nerve that rides underneath the ligament that goes in the opposite direction the nerve runs. and it's analogous to carpal tunnel syndrome. So many folks can develop a pinched nerve, and it usually occurs between the third and the fourth toes.
Mm-hmm. Yep.
Is that where yours was?
Yes.
Yes. Okay.
So when someone comes in to your office, and what's their chief complaint? What are the signs and symptoms?
Yeah, most of the time they'll complain of burning tingling out towards the third and fourth toes. Sometimes they feel like there's a balled up sock or something in their shoes that they have to check periodically, and they notice that nothing's there. And oftentimes it's just burning pain on the plantar aspect.
It hurts a lot.
It hurts a lot.
Oh my gosh.
What did you complain of? What did you tell me?
Whenever I'd walk on that part of my foot, I was like, I can't walk. I have to walk on my heel. Like, it hurts so bad.
And do high heels make that worse?
Some do, yes.
Okay.
So it depends on how tall they are. But some flats even, like if it's like the right, I don't know, it just hits it at the right spot. And I don't know, it's weird.
Yeah, they are painful.
Very,
I'd say over
painful.
50% can be calmed down with usually injections, but there's a good portion of these that do require surgical correction. But I think you're doing okay. We're going to stay away from...
Yes, no surgery.
We don't need any sharp objects towards Abby.
No
We've done enough.
Exactly. Okay, so let's move on and talk about your background. And those of you who are watching, if you guys have any questions along the way for Dr. Briggs about anything foot related, we'll try to answer your question.
We're back.
And sorry, had a phone call. Okay, let's talk about why did you want to become a doctor?
Good question. I don't know. No, I was a kinesiology exercise phys major at the University of Colorado and came across podiatry and foot and ankle surgery at that point, and I thought that would be a good complement to my undergraduate degree. I applied to medical school at that point and did my training at the California College of Podiatric Medicine in San Francisco. And then I went on to do a residency in Los Angeles, affiliated with UCLA, and then did my rest of my surgical training here in Houston for the following 2 years.
So Colorado and then California.
And now I'm in Texas.
What made you decide Texas?
A lot of people that finish residency end up in the town that they did their residency in, and I think you start to build connections and a comfort level, and I think it was appropriate that I stay here at the time.
Awesome. Well, so you talked about where you went to school. How long have you been a podiatrist?
I can't believe I'm telling you this, but 16 years.
Wow, awesome.
Yeah.
So, and you're a part of Texas Gulf Coast, which is right next door to the hospital.
That's correct. I joined them in 2011. I was down from Alaska, where I was practicing for 3.5 years. And
whoa, you didn't say Alaska.
I never told you that.
You said California.
Yeah,
you said Colorado, California, and Texas. You didn't talk about Alaska.
Okay, so after my residency, I stayed here in Houston for about 5.5, 6 years. And then my wife and I had an opportunity to work up in Anchorage, Alaska. And we did that for 3.5 years and realized it was time to come home. And we came home to Houston, and we've been here since 2011.
Good. Oh my gosh, was that freezing cold?
A lot of Eskimo feet.
Oh yeah, I'm sure that was interesting.
Yeah, a little bit of frostbite, a little bit of injuries.
Wow, that's so cool. Huh, did not know that about you. Okay, let's talk about where your office is located.
So we're located at 250 Blossom, right next to the hospital. We're at the first floor, Suite 100. Webster, Texas.
What's your phone number if someone wanted to make an appointment with you?
281-724-0368, and that's our main number to get to our office downstairs.
Awesome. And it looks like we have a comment right here. My back heel has been hurting since Harvey and wanted to know what causes this sharp pain.
I would tell you just at first glance, and oftentimes it's the insertion of the Achilles tendon, and sometimes you can actually develop a bone spur on the back part of the heel. Certainly something to get looked at. If those situations become more chronic, it's much more difficult to treat conservatively. So probably and possibly Achilles tendonitis at the insertion of the heel bone. However, there are several other medical and foot and ankle conditions that can cause heel pain, so it's probably important that you get that checked out.
And if you want to learn more on their website, it is gulfcoastfootankle.com, or you can call 281-724-0368. All right. And I wanted to, any parting words before we go? Thank you, Laura. Thank you for your question, by the way.
You're welcome.
Any parting words before we go?
I just wish everybody to have happy feet and keep active, okay? Certainly if you can stay away from a foot and ankle surgeon, all the better. However, Just because you have a foot and ankle condition doesn't mean you need surgery. There are many things that we can do conservatively to keep you going. So, but I wish everybody the best. Again, our job is to help you keep active and do the things that you want to do in life.
And there's a couple more comments rolling in. Hey, Terry says, Dr. Briggs is the best. That's awesome. Thank you,
Thanks,
Terry, for
Terry.
your comment. Okay, so you guys, we're going to be live again on Tuesday with Bay Area Regional Medical Hour, Tuesday at 4 o'clock. We're going to have 2 doctors that will be live with us. We'll have Dr. Dipsu Patel talking about all things heart, because it is February now and it's Heart Month. So we're going to be talking about all things heart with Dr. Patel, and we're also going to have Dr. David Michael Washington, who is also with Texas Gulf Coast with Dr. Briggs, talking about kids and viruses, asthma, and ADHD. So you guys come back 4 o'clock Tuesday and we'll check it out. Thanks so much for coming today. Talk
Great
to
to
you
see
soon.
everybody.
Bye.
Bye-bye.